Hello, everyone. We have quite an audience tonight. This is Jenny Cover. I'm on the board of Axis. It's my pleasure this evening to introduce Dr. Nicole Tartaglia. She's also known as Dr. T, especially to her younger patients. Dr. T is a developmental pediatrician who's made extraordinary contributions to the X&Y variations community. The most significant contribution for many of us who are parents is that she established the Extraordinary Kids Clinic at Colorado Children's Hospital, which was the first multi-specialty clinic serving children and young adults with sex chromosome aneuploidy. This clinic provided the model for other clinics, which now form the Axis Clinic and Research Consortium. Dr. T also has been very successful in carrying out funded research, competing and being awarded scarce NIH research grants to conduct studies into X&Y chromosome variations. She's published a large number of medical articles that have contributed to our knowledge of X&Y variations and helped guide the development of treatment recommendations. She's a genuinely nice person. She never talks down to either parents or her young patients. So without further delay, I'll give you Dr. Nicole Tartaglia.
Thank you, Jenny. That was a very nice introduction. So it's a pleasure to be here tonight. The topic of my talk tonight is X&Y chromosome variations from birth to age 5, and we're going to talk about developmental and medical care. And I think it's good to get going. I think what's going to happen is that if you have questions along the way, you can type them in. The webinar is scheduled to go for about 90 minutes. And we probably have about an hour of slides, and so we'll go through that hour of slides. So please feel free to type in questions as we go along, and then the other monitors, Ginny and Robbie and others, will be monitoring those questions, and then at the end we'll batch some questions together that are similar themes and answer some of those questions and can take some additional questions as well. Does that sound correct, Robbie, Ginny, everybody?
Yes.
That okay. Sounds correct, Nicole. Thanks.
I just want to make sure I'm giving people the right instructions. Okay, so the outline for tonight, I'd like to talk a little bit first, just a general discussion about risks and variability in the X&Y variations. Then we're going to talk a little bit more specifically about developmental milestones and developmental screening and assessments, and what our recommendations are, usually from the Extraordinary Kids Clinic, in terms of developmental assessments for young kids. We'll talk a little bit more specifically about some of the specific therapies and interventions as well, some different aspects of medical screenings and medical care in the young children, and then I'm going to want to spend some time on some really fun and awesome and I think very innovative new research opportunities that are going on right now. And it's a very opportune time for families who are interested in research, who have young ones, to participate, because we have 3 different studies that different populations will be eligible for. An Extraordinary Babies study that's funded by the NIH for a grant to myself and Dr. Judy Ross at Thomas Jefferson and Nemours. The TRIXY study, which is the PI is Dr. Sophie van Rijn at Leiden University in the Netherlands, but we are one of the 3 sites of that study. And then the TESTO study is a study for infants with XXY, led by Dr. Shanley Davis, a pediatric endocrinologist at the Extraordinary Kids Clinic in Denver. So I'll talk about those studies as well at the end, and information for families who might be interested. So just to start, X&Y chromosome variations as a group occur in 1 in 400 live births. Anytime there's extra X and or Y chromosomes, there are different phenotypic and developmental and medical features. The most common are the 3 largest circles there, which are the trisomies, XYY, trisomy X, and XXY, are also called Klinefelter syndrome. But then there can be any other variation of adding extra X's and Y's, up to 5 different X's and Y's in males and females. And then the TS down there stands for Turner syndrome, which is a missing X chromosome in females. And we're actually not going to talk about Turner syndrome tonight. We'll spend the majority of the time talking about the trisomies because that is the biggest group, but we also spend a lot of time at the Extraordinary Kids Clinic working with XXYY and other variations, and so all of what I'm going to be saying tonight applies to all of the different variations. In general, the conditions that have more than one extra X chromosome, so the tetrasomies with 4 X and Y chromosomes, or the pentasomies with 5, generally have more frequent rates of developmental delays and learning challenges, and then also some more complex medical problems at times. And so, so in the end, if people have specific questions, we can go through and differentiate the different syndromes. But in general, most of what I say tonight is applicable to all of them, and I will let you know when there's differences. So, you know, I think one of the most challenging things about working in the field of the X and Y variations is the variability between individuals. And so we know that within the same condition, individual children exhibit very different degrees of developmental differences and the physical and medical findings. And so while we know there's common risk factors and common challenges that go along with the X and Y variations, definitely not every child has all of the problems that we talk about. And so, you know, so I think it's always important to start with that, because if some of this doesn't sound like it's applying to your child, or if all of it sounds like it's applying to your child, it's because there is that much variability within the conditions. So what we like to do, and kind of how I frame it when families come to clinic, is that an X and Y variation is really a risk factor or a genetic vulnerability or susceptibility or predisposition. There's a lot of different ways to say it, but the idea is that the X and Y variation comes along with the risk or susceptibility to different neurodevelopmental differences and different health conditions. And again, not everybody is affected, but there are common health conditions or developmental differences that we see, and having an X and Y variation is a risk factor for that. So if we talk about that just a little bit more, you know, what is genetic susceptibility or vulnerability? What that is by definition is the genetic condition itself carries an increased risk for other conditions. And so, but just because that has that increased risk, again, not everybody at risk will develop whatever condition we're talking about. So additional factors then increase or decrease the likelihood of developing whatever the different outcome is. And to show a little bit of an example and think about this in a picture format, the little girl on the left is a little blonde girl or a redhead girl with very, very fair skin. And we know that population of patients is at higher risk of having skin cancer. And so on the right, you see a melanoma, which is a skin cancer. But we also know that there's factors that increase that risk, right? If you have a lot of sun exposure, you're going to have increased risks. If you have maybe other family factors that predispose to cancer or predispose to skin cancer, then that might also lead to a higher likelihood of having the condition in the end. But there's also protective factors, right? There's protective factors like sunscreen and hats and all of those things. And then there's also, you know, protective factors like sunglasses and other things that you can do. And so, you know, anytime we're talking about kind of the risk of an outcome, we want to think about what some of those risk factors might be, and then also what some of those protective factors might be. But knowing, you know, knowing about the susceptibility and the risk allows us to screen proactively. It allows us to implement timely interventions, and it allows for better outcomes in the end. So we're going to speak a little bit more specifically about some of the increased risks in the X and Y variations. We know there's increased risk for early developmental delays. And one of the biggest areas where we see challenges that can come up is in speech and language areas. And so, you know, the goal of watching and screening for early developmental delays is, you know, really to identify if delays are present so that we can implement interventions, but not just with the idea of having them kind of, you know, catch up to whatever is typical for their peers, but also in thinking about how that risk factor early on in life then also can contribute to some of the challenges that we can see in X and Y chromosome variations later. And so we know speech and language skills just fundamentally then lead to and are important in reading and academics later on. They're important in communications and conversations and social skills. They're important in how kids express themselves. If they have challenges with communication, oftentimes we can see a lot of challenges with behavior. And clearly all of these things all together can then also affect self-esteem and quality of life. And so, you know, from our goal of identifying challenges early on is really to hopefully treat and improve those challenges early on, so that we can also then have a longer lasting effect on those outcomes in later childhood and adolescence and adulthood. So when we talk about the X and Y variations, we know that there's a few things that do affect that variability. One of them is genetics just itself. While everyone might have an extra X and or Y chromosome, there are some times where there's a condition called mosaicism, and that basically is the idea that some of the cells may have typical chromosomes in them. So there might be a child who has trisomy X in 90% of her cells, but 10% of the cells would have mosaicism, where it would show just the typical XX cell line. And you can have mosaicism in all the different variations. So the higher the percentage of typical cells that there are, the more likely there is to be more typical development or health in those conditions. And then we're going to usually see a less affected individual. And so that is one thing we know, that if you look at big groups of individuals who have mosaicism, they tend to have fewer of the features compared to kids, to a group of individuals who don't have mosaicism. We also know that background family genes can contribute to the different outcomes. And so family cognitive abilities, family IQ, family learning style definitely can have a correlation to the outcomes of the child. And so many families who, you know, have very high academic skills, generally in families that can run in families. And so many times those children who come from, you know, more higher cognitive families with higher cognitive abilities also tend to have higher IQs. However, the other important thing is that, you know, families where there is a risk for learning disabilities, ADHD, anxiety, or other mental health problems that run in the family, those can then also be a second contribution to the risk that we can see in the X and Y variations. And so, you know, many families worry, oh no, I also, you know, had learning challenges when I was young, or, you know, I had attentional challenges. But many times, even though that does confer a little bit of extra risk to the child, the parent is much more aware of how those behaviors and those features can affect individuals. And so many times kids who have parents who did have learning disabilities are at an advantage in some ways, because their parents really understand them and understand what they're going through. And so in many ways it can be a positive as long as it's you know, addressed in a kind of healthy way. We also know about the environment. Stable home environments, decreased early life stressors lead to longer term improved outcomes, and that's been shown in previous studies that where there were many babies who were followed from a diagnosis right at birth and then followed all the way into adulthood, and these were some of the factors in terms of the environment that led to improved outcomes. And then in terms of health outcomes, diet and physical activity, nutrition, exercise habits, all of those more healthy lifestyles also leads to, you know, improved health outcomes overall. And so many of these things are not unique to the X and Y variations. We know all of these things affect outcomes in typical children as well, but I think they're always important to talk about what we do know from the research in these populations. So we're going to talk a little bit more specifically about the different developmental domains that we look for and monitor in the X and Y variations. We've already spoken a little bit about speech-language skills, and so when we start to evaluate speech-language skills, we evaluate receptive language, we evaluate expressive language, and then speech production and speech sound. So receptive language is the understanding of language, understanding of, you know, different directions and vocabulary, and doesn't require expressive language. Expressive language is the actual formulation of language itself and what kids say and how they express themselves. And then obviously then there's the actual speech piece itself, where kids learn to speak in terms of speaking intelligibly, and when there are difficulties with intelligibility for things like lisps or other kinds of problems in terms of that actual speech, then there's articulation and other types of therapies that can be implemented. We also look at motor skills and usually divide that into gross motor skills, which is kind of your bigger muscles and your whole body movements, and then fine motor skills, which is more kind of the motor skills of your hands and fingers in terms of doing fine motor movements. Cognitive and problem solving is another domain that we look at. So this kind of takes out the speech and language and motor components and just, how do these kids solve problems without having to require language or motor skills. So this is often lots of puzzles and patterns and other types of problem solving. And then we look a lot at social emotional development. How is a child developing in terms of play skills? How are they learning to do imitation and early types of pretend play? And then how does that extend as they get older, using eye contact and gestures to communicate? Social skills and using those social skills to get their needs met and to share enjoyment and play is part of one of those jobs of childhood. And then, how you self-regulate or manage your emotional feelings and your emotional reactions when there is a setback or where there is a challenge is also something that's an important factor in terms of social emotional development. And then the last area that we look at is what's called adaptive functioning, or more kind of life skills. How are kids doing in terms of gaining skills and independence in things like dressing and eating and toileting and getting around in their community. And so these are things that obviously in infants we don't have a lot of expectations, but as these kids get older, these are skills that we expect them also to begin to learn. And so whenever we do developmental evaluations in patients, then these are all the different areas that we really want to think about, because in the X&Y variations there can be delays and challenges in all of these different areas. So milestones themselves are measured and talked about in many different ways. This is just some pictures from various developmental milestone charts. And so, I think one of the biggest and important things is that there definitely is a series of milestones we expect and watch for kids to meet as they grow up. But there's also a lot of variability around that. And so I think the most common milestone most people understand is kind of that, well, they should be walking by a year of age. And, that is a milestone in terms of, on average, kids start to walk around 12 months of age. However, as they, there's a lot of variability around that. And some kids walk at 9 months and some kids don't walk until 14 months. And, all of that is still within typical development. And so, when we're talking about milestones, it's always important to remember even within those milestones, there's a lot of variability as well between kids. So when we talk about monitoring for developmental delays, there's different levels of monitoring. And the first one is what's called developmental surveillance. And so this is basically if you're a primary care doctor or teacher or someone else just starts asking questions about development. Oh, can he write his name yet? Can he roll over yet? Can he do this yet? So many times these surveillance types of questions are questions about developmental skills. And they're important to ask those questions because it starts to elicit and give a picture of what the child's doing. But surveillance itself, just asking questions, is not enough in terms of what we need to do for kids who have X and Y variations where we know there's a risk for having developmental delays. So we want to have a little bit more rigorous and standardized ways of evaluating all the different domains that need to happen. So the next step is what's called developmental screening. And this is usually the use of a standardized instrument, so an instrument that's been designed to screen for delays and or social development or autism spectrum disorders. And this is a part of typical pediatric care. So any child at their primary care office, the American Academy of Pediatrics recommends that at well child care visits, there is a developmental screening instrument that's used. And so most people have seen some of these screening instruments, and basically it says, can your child, crawl or walk upstairs alternating feet? And you say, yes, they can do that. Sometimes they do that, or not yet, they're not doing that. Or there's many different ones. So one is called the Ages and Stages questionnaire. The PEDS is another developmental screener. The MCHAD is one that's often used for autism spectrum disorders. And all of these are recommended as part of normal and typical developmental care for all kids. And so, this is something that most pediatricians and primary care providers should be familiar with. And, after the questionnaire is filled out, there's usually a cutoff score for where there's kind of a caution or an at-risk if there's a domain or more than one domain where the child isn't doing what we would expect compared to other kids their age. And we'll talk a little bit more about screening in the next couple slides. And then finally, screening doesn't actually identify if there's a true developmental delay. It just tells you if there's kind of a caution or a risk that needs further identification or further evaluation. And so the next step is actually the full and true developmental assessment. And this is a much more comprehensive evaluation directly of the child, using a lot of standardized tools and toys, and then the expertise of a clinician to determine if indeed there is something that is a diagnosable developmental delay that would then indicate the need for other therapies. And this is done, again, a lot of different ways. There's oftentimes a lot of kits with various toys and pictures and books, and it allows us to, in a play-based manner, evaluate the child and see what their skills are. Like I was saying before, the surveillance itself, asking the questions, is really important, but we definitely need more for the kids with X and Y variations. And so, our kids are at higher risk, and so that's why we definitely want to make sure that we're using a step beyond surveillance. But if you're interested in surveillance, there is actually a really cool new kind of do-it-yourself surveillance app. Of course, now there's an app for everything that was developed by the CDC, and it's actually a milestone tracker, and you can download it, and it has, a lot of really good information about the different milestones at different ages that you should be expecting, and then it gives you these little summaries that you can share with your doctor, and it has a lot of different activities as well that kind of help with different areas if you're interested in looking for those. And so, this app is one that, I checked it out, and I actually think it's kind of cool. And it came out recently. So this would be, if you're doing it yourself, remember I put with caution in there because there's two things you have to be cautious of. Number one, it doesn't replace going to the primary care doctor and doing real developmental screening or developmental assessments. And then number two, you also don't want to be too paranoid about monitoring every single milestone. And so, I think it's really important that we're monitoring these milestones, but we don't want you, kind of, I don't know what the right word is, making your baby into a little experiment where you have to log every single thing they do and then forgetting kind of about the whole child, right? And so, you want to, do this just with caution. We don't want you to worry about these things too much if there's just one little challenge, but to use this as a tool to then be able to go talk to your doctor if you have concerns. So then in terms of developmental screening, this is a picture again of kind of what those screeners look like. And it is recommended at every well child care visit by a primary care provider. So anytime you're going in 2 months, 4 months, 6 months, all the way up through all the school age years, there should be developmental screening that's completed. And then social and autism screening usually starts at 16 to 18 months of age. And again, that's for all children. And so definitely includes the X and Y variations where there is a slightly increased risk of autism spectrum disorders as well. If your PCP or primary care provider is not doing it, then ask them to. And so I think you can say, hey, the Access website and the doctors all recommend that we're doing some kind of formal developmental screening. So one of the measures that they recommend is the Ages and Stages questionnaire, or there's also there's a lot of different toolkits in terms of what providers can access through the American Academy of Pediatrics. And so if they don't have it, then I would say, I would definitely make sure to advocate and say one of the recommendations for caring for our kids is that they have developmental screening. And so that would be, really important in ongoing care. And then we talked about the more comprehensive developmental assessments. So these should definitely occur if there's an at-risk or a concern on the screening assessment. And so if something comes up on those screens that says, oh yes, there is a speech delay, or there is a concern for fine motor skill delays, or something else, then that should be an indication that they should be referred for further developmental assessments. And then I recommend that a full developmental assessment is actually done at specific time periods for the different X and Y variations because of the high rate of delays and challenges that we can see in these kids. There are some times where I still feel that even screening isn't quite enough and that we really should be doing a more comprehensive assessment to monitor the progress of these children. So a developmental assessment, and I'll talk about those time points on the next slide, but the developmental assessments can be performed by many different types of people. It definitely can be performed by medical providers who are trained in neurodevelopment, so that's a lot of different types of providers, developmental pediatricians, and so there's two different types of developmental pediatricians. I'm a developmental behavioral pediatrician, but there's also pediatricians who are specialized in neurodevelopmental disabilities, and so they also do a lot of developmental evaluations. Child neurology sometimes does, child psychiatry sometimes does, pediatric rehabilitation. So there's a lot of medical providers who can do these. And basically the question to your primary care provider is, where do you send patients for further evaluation? And they usually have people identified in your community where these patients can be referred. Child psychologists also do this, who are expert in early child development, and then early intervention teams and school district teams. So sometimes there will be other teams that come out to your house to do evaluations and determine if they're eligible for services as well. And then other therapists as well. If there's concerns about speech delays, and the speech and language therapist can do an evaluation related to those speech and language skills. And then there's many other different types of providers who might be able to perform these as well. But this is generally the main list of people who would be doing this. The other thing that's important from the perspective of ACCESS is that in the ACRC, which is the Access Clinics and Research Consortium, there's now a network of clinics nationally. I think now there's 6 or 7 clinics, and many of those clinics also perform developmental assessments and have some additional expertise in the X and Y variation. So those would be places also that you can go for developmental assessments. So these are the time points that I usually recommend that there are developmental evaluations done for the X and Y variation. So usually, many times infants are diagnosed prenatally, so we have the opportunity to be able to monitor from early on. But sometimes kids are diagnosed later on because of developmental delays or because of other reasons, and so then they're diagnosed after birth. So, these are the time points in terms of, if you have a prenatal diagnosis, for example, but then if you have, a diagnosis that's made at 24 months, then obviously you would kind of start at that time point and then move forward from there. And so these, developmental evaluations should include all of those domains that we talked about before, the cognitive skills, the motor skills, speech and language, social skills, and adaptive functioning, which is the life skills area. And so, and I think that's an important and comprehensive evaluation because of all the risks that can be associated with the X and Y variations in those areas. And then if those evaluations identify concerns, then we would seek then the next step, which would be therapies or interventions to be able to support those. And we'll talk a little bit more about those as well. So there's many different types of therapies and interventions. There's 2 kind of main ages for when we talk about intervention in this kind of 0 to 3 years of age. It's usually what we would call early intervention services. So IDEA is the Individuals with Disabilities in Education Act, and Part C is the part of the law, it's a national law that mandates kind of that all states and communities have access to early intervention services for kids who are 0 to 3 who are showing developmental delays and or who may be at risk for developmental delays. So in many states, just having an X&Y variation is a qualifying diagnosis, which makes it that your child would be definitely eligible and qualify for receiving early intervention services, even if they may not have a clear developmental delay yet. And so it depends on your state, but some states will just qualify you for services and monitoring just because of the diagnosis. In other states, it requires that you actually show that you have a developmental delay. So if you had a child who was diagnosed with an X&Y variation because they had delayed, then obviously you would qualify here. Or if a developmental delay does develop, then you would also qualify. And then usually in this area, you qualify for what's called an IFSP, an Individual Family Service Plan. And basically it's an individual plan that talks about all the current skills of the infant or young child below 3 years of age, and then what the goals are in terms of, the areas where that child could use some support, and then there's a plan for how that's going to get there. We're going to do, speech therapy once a month, we're going to do speech therapy once a week, or something else. And usually, these therapies are delivered in the home setting, unless families for some reason don't want them to be done in the home setting. But generally families prefer that they're done at home because it's a lot easier. You don't have to travel to therapies. And then kids generally tend to do better in a setting where they're more familiar. So most of the time, early intervention services for our patients with X&Y variations are delivered through these Part C programs. But then there are other times where we will recommend that they may get additional private therapy. The strengths and abilities of some of the early intervention providers in different places varies a lot. And so if we see a child where we really feel that there's a really important need for physical therapy or speech therapy that doesn't seem to be progressing with the early intervention services, well, then we would definitely refer them on to also get private therapy through the hospital or through another private therapy clinic. After 3 years of age, the kids then transition into what are called Part B services, or these are the services offered through the school district. In most urban areas, the school district manages all of the special education services, including the different therapies. In more rural areas, sometimes it's managed more by a kind of regional special education center within that area, and then they kind of are distributed out to all the different schools. But in general, the therapies, once you get to 3 years of age, the therapies are delivered in a preschool setting with what's now called an IEP. An IEP stands for an Individual Education Plan, and that again is an individualized plan that looks at the strengths and then the needs for each individual child to determine what types of therapies they may need. There is often, especially for kids who may have more challenges in terms of their developmental skills, when the transition happens from, home-based therapies to the school-based therapies at 3 years of age, sometimes families feel like, whoa, there's a lot of benefits to that. The kids are in preschool, they're, interacting with other kids, but then they're also receiving those therapies in the school setting. And so families aren't there anymore to interact with the therapist and learn from the therapist. And honestly, for these really young kids, many of the hours spent in therapy are spent with the child, but they're really spent with the child and the parent, teaching the parent strategies to stimulate, language development and communication, to help their child in terms of motor skills. And so the parents are learning a lot along the way with the therapist, and then those things are then, implemented when the therapist leaves. But when school, if it's all happening in the school setting, then parents don't always know exactly what those goals are and what's going on because they're not there in therapy all the time. So there are many times where after there is that transition to the school district, if it's a challenge in terms of communication and or if it just feels like they're not making as much progress with the school-based therapies, then it's a time where we often will add private therapy so the parents can continue to be involved in the therapy settings. Okay, so now there's just a lot of different types of therapies, and obviously the different types of therapies that kids qualify for and what they need is very different depending on the child. So sometimes there are kids who may need just one type of therapy. Other kids may have more severe challenges and need, multiple different types of therapy. And then the different types of therapies offered actually through the various districts and programs can be different as well. And so developmental intervention is usually just a general therapy that offers, various developmental skills across all of the different domains. Speech and language therapy, like we talked about, obviously would target speech and language skills, but also often targets play and social skills. And sometimes if there's feeding difficulties early on, some speech and language therapists are trained in that, and so they can also help provide some feeding therapy as well. Occupational therapy is, can be also target a lot of different types of domains and a lot of different types of skills. So the occupations of childhood are playing and eating and dressing and regulating behavior and all those jobs and things you need to do as a young kid. And so this these therapies will, look at the fine motor skills of the child and work on those skills. They'll work on a lot of self-care skills like buttoning and dressing and eating. Kids who have a lot of sensory processing challenges, a lot of sensory sensitivities, or they get very dysregulated in more noisy or busy environments and have a hard time self-regulating, then occupational therapists have a lot of strategies for those. And it's often really helpful, especially in the young kids, because at those ages, a lot of the behavior and some of the challenges with self-regulation and tantrums and other things are hard to, it's hard for kids to, be involved in trying to regulate, and talk about their emotions, right, when they're really young. And so there's a lot of very visual strategies and kind of play-based strategies that OTs will use to help regulate and help with self-regulation so that behavior can be more even. And then also occupational therapists are also often well-trained in feeding. And so if there's feeding difficulties, they can also support those needs as well. Physical therapy usually works more on gross motor skills and balance and coordination, and so that's usually part of a treatment plan in a child who might have more gross motor delays. And then behavior therapists can also be involved as part of a treatment team. And there's different types of behavior therapists, board-certified behavior analysts, or therapists who do what's called applied behavior analysis. And these therapies are meant to kind of reshape or change some of the behaviors that might be more challenging and or help build behaviors and skills that may need to be built. And so many times these are implemented for more challenging behavior concerns or skills that need to be developed in autism. But there are some times where ABA will be applied for kids who just need to build skills or have milder behavioral challenges, depending on the availability at the different locations. So when we talk more specifically about, the actual speech and language challenges in XXY and XYY and XXX, what we know about these conditions is that there's about 50 to 75% of kids, based on previous studies, end up having some degree of speech and language delays. And there's a lot of variability in some of the studies that have been out there. Most of the research that we base these percentages on is the research that looked at newborns in the 70s and 80s, where there were big populations of newborns screened at birth, and then those newborns who ended up having an X and Y variation were then followed all the way up through adulthood. So they're very old studies, but they're also studies that are well designed because they don't have a bias of having kids in them who were just the kids who were identified because of delays. And so it gives us a little bit more of a kind of pure picture of what the variations do instead of just identifying kids because of clinical challenges. And so if you see here, you can see kind of the spectrum of the different delays. There's definitely a chunk of patients who do not show any early developmental delays in speech and language skills and who kind of go along just fine without needing any types of therapies. And then you have some who have milder therapies or milder delays, more moderate delays, and then more severe delays. And I would say for the trisomies, the more severe delays are usually, it's a smaller percentage of patients. For those who have tetrasomies or pentasomies, there's generally more significant speech and language delays compared to the trisomies. So some of the things you might see are delayed babbling. We typically expect that there's going to be 4 different consonant babbling sounds by 6 to 7 months. So that would be ba, 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 ma, 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 la, 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 ga, 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 goo, goo, goo. And so sometimes we don't see quite as many consonants as we would expect. And those babbling skills may come later, more at 8 to 9 to 10 months, or they may have those consonants, but they're just not using them as frequently as you would expect. So overall, kind of in the course of, an evaluation for us, we might hear, 4 consonants, once or twice, compared to what we might expect in typical kids, where you would hear it a lot more frequently. And then many times we'll see delayed first words. Usually by 18 months, we expect that kids have about 18 words. Sometimes they have many more words than that, but one of the things I really look for is, do they have 18 words by 18 months of age? And then many times in the X and Y variations, our first words can be a little bit delayed, and then the vocabulary does not build as quickly as typical infants. And then there can be delayed 2-word phrases as well. Usually we expect that kids are starting to put 2 words together by 2 years of age. And so some of the phrases that we might expect to see are things like baby night night, or doggy go, or some of those types of really short little phrases that show that they're putting 2 words together. There's some 2-word phrases that kids will say just because they learn them as kind of one rote phrase, like let's go or all done. So even though those are technically 2 words, unless they're using each of those words separately, it doesn't count. So if they only say let's go and that's all they say, then that doesn't count as a 2-word phrase. But if they say let's go, daddy go, baby go, then they're definitely using that more flexibly, and those would count as a 2-word phrase. There's another aspect of speech and language development in the X and Y variations that's called apraxia of speech that's also very important to talk about. So this is also sometimes called dyspraxia of speech, developmental dyspraxia, developmental apraxia. So there's a lot of words for it, and different people will define this differently. But generally, it's the deficit in the connection of the brain with the muscles of the mouth and lips and tongue that leads to difficulties with speech production. So that connection and that communication of how to get all those sounds and words made is not as strong and not as consistent as we would see in typical kids. And so there can be a lot of variability in how sounds are made and how speech is produced. And that's just a really important example of why screening and monitoring with some expertise in understanding the X and Y variations is important. Because if we identify apraxia of speech, then there's definitely different therapy techniques that are used compared to kind of more standard therapy for language delays. Because the therapists then work with the kids a little bit more on actually, that production of sound, whereas they might not be doing that if it's just more of a kind of vocabulary delay. And so this is one example of where, knowing about the X and Y variation and then knowing that this is a risk factor, really lets us identify this a lot earlier. Many times this might not be diagnosed until 5 to 7 years of age, but we know that because this is a pattern that can develop later on, if we're seeing the early signs, then we want to start to treat it then. And so an experienced speech-language therapist should be able to tell and evaluate for these differences. But I do think it's important for parents to say, hey, kids with X and Y variations are at risk for apraxia or dyspraxia of speech. Do you see any signs in my child? so that then if it is an appropriate mechanism or an appropriate avenue of therapy, then that piece of therapy is also added to the therapy program. There's also increased risk for motor delays, and in the trisomies we see not quite as many motor delays as we generally see in terms of or compared to language delays, but about 40 to 60% with fine or gross motor delays. And so again, these are usually, when they are present, more in the mild to moderate range and less frequently severe, but sometimes they are more severe. So generally, we expect kids to sit independently at 6 to 7 months, and this can be a little bit delayed in some of the kids with X and Y variations, often because of sometimes decreased trunk and core strength. And so some of those skills that require a lot of core strength and core development can be more delayed. Delayed walking, typically walkers, start walking independently at 11 to 13 months, and that can also be, on average, a little bit later in kids with X and Y variations. Usually the average is more kind of 14 to 15 months, but we definitely see, a lot of variability there as well. And many who don't have any challenges, and then challenges with motor coordination and balance and other things. So with motor delays, just thinking about it kind of in the same way compared as we did previously for language skills, motor skills also really contribute to a lot of important things and important aspects of, life later on. So definitely motor skills are needing for writing and academics and, art class. Motor skills are needed for self-care and independence. And then motor skills then later, are really important, obviously, for physical activities, for sports and social opportunities, and then for just overall cardiac and muscular and bone health as well. And so, the reasons we're monitoring and watching for these things so carefully is so that we can really implement those interventions to then later on go on to, hopefully improve all these other aspects of life as they get older. So families often have a lot of questions. What can I do to help my child? We know we have either a prenatal diagnosis, or we know we have a child who already has delays. We're doing all these therapies, or some people, we're not even in therapies, but what do I do to help them? And there's, so many things that are out there, and Baby Einstein, and how are you going to make your baby smarter, and all these different apps and things. And I think one thing is just to make sure that families know that you have to be really cautious about what these tools can do. It's definitely important to stimulate your child and have opportunities in many different settings to be able to be exposed to music and to be exposed to books. And there's nothing wrong with working on ABC Mouse on the iPad a little bit, but we definitely don't think that the kids should be sitting there doing ABC Mouse for 2 hours a day just because the commercials sound like they're so great, right? And Baby Einstein, it's fine if it is something that your baby likes and enjoys, but it's definitely not necessary. And there's so much pressure, I think, today in terms of just society and making our babies smarter. And we do want to stimulate them, but there's also kind of an excessive amount of stimulation that can be there that can be detrimental, because then they start to think of everything as therapy. And so anything that's fun and enjoyable and giving them good stimulation is fine, but obviously we don't want to overdo this or think that these are going to really baby Beethoven is not necessarily going to really make significant differences for each individual as much as they kind of might promote that they do. But definitely books and reading and other things. So, the things we do really recommend are obviously the developmental screenings and assessments as recommended, the therapies if needed. Don't overdo it like we talked about. So you can definitely over-therapize and make babies and kids not want to do anything that's challenging, because if you're giving them challenging stuff to do all day long, then they're going to start to resist that, and they might start to resist the therapies themselves or the activities that you bring out that look like they're going to be hard for them. So, some of the general things are to, just be really positive and narrate and talk a lot about what you're doing. Hi, I'm putting on your shoes right now, and I'm fixing dinner, and I'm going to cut this in half. And, now I'm going to stir, my soup up. And just, it has been shown that the amount of words that families use can be stimulating to language development. But the other side of it is that you don't want to overwhelm your baby too. So if your baby is one where you can see that too much, too many words or too much language overstimulates them, then that's that's going to be something that that is negative. So you really have to read the baby as well, and read your child. I think one really important thing is that when there are apps or other things used, that it's important to generalize those concepts in different contexts. So maybe someone's learning all their ABCs on the computer and they can do, the whole app and they know how to do everything. Well, that doesn't necessarily mean they've learned it. They've learned it in that context and on that app. But they have, to really have learned their letters, they have to be able to, recognize letters in books and recognize letters on signs and recognize letters in different places. And so if there is a concept that you're, working on with your child, and they've, they seem to be, oh, they're doing so great on the app, then you want to generalize that in day-to-day life settings also. Books and enjoying books and looking at pictures and talking about what's going on in the books, can be very important and helpful, and fun activities with your kids all the way, through adulthood even. And then making sure to find fun activities that don't involve therapy, that are just fun to build self-esteem. And so finding those strengths and working on and giving as many opportunities for areas of strength and developing areas of strength and interest as we do, working on the areas of challenge, because none of us want to sit there all day and work on things that are hard for us. It's going to, make us really depressed and discouraged. And so making sure to have that balance, I think, is really important when you're raising kids who may have developmental challenges. So now we're going to shift a little bit to some of the medical care from birth to 5. If there's a prenatal diagnosis, so that means that the genetic testing was identified, the genetic abnormality was identified before birth, then one of the things that's really important is to make sure you also have postnatal genetic testing to confirm that diagnosis. Sometimes those prenatal diagnoses are incorrect and or, don't have all the information that you think. So we've had, some families where they get a prenatal diagnosis, and then when they do postnatal testing, there might be mosaicism that wasn't identified, or there might be, we've had one or two where there's been a prenatal diagnosis of XXY, but then postnatally it was actually XXYY. And so those are situations where it's just important to know, because it lets you better understand that child. The other reason is that any prenatal testing is usually done in the mom's name, and so there's no evidence or record of that child having the condition unless they have a blood test that's in their name after birth. And so that's really important to have in their medical records to document that they actually do have the genetic difference after they've been born. Most of the time, if you know prenatally, you talk with the delivery team, then you can get cord blood, and they can just, they'll often do the genetic testing from the cord blood right at birth. Or if they're in the hospital for a day or two after birth, they can collect a little bit of blood when they're doing other testing to be able to be sent to the lab for postnatal testing. If they haven't had postnatal testing and they're a little bit older, it is something that we recommend. It's obviously not urgent, but if there's any time you're having any other blood drawn, then it's an important time to do it. And then some places will now do it by cheek swab. And so you could ask whether or not it can be done by cheek swab as well, where they can analyze the cells that way. So in terms of, talking about the other body systems, so cardiac abnormalities or heart abnormalities. So there's slightly increased risks of congenital heart malformations in the X and Y variations. In our study, this study actually is for girls with trisomy X, but we've actually seen this in all the different variations in boys with XYY and in boys with XXY, and more frequently in kids with tetrasomies and pentasomies. And so usually if there is a malformation there at birth, it's pretty mild. It's usually one of what they call the septal defects. So it's just a kind of hole or between the two different chambers of the heart. Of the ventricles are the main chambers of the heart on the bottom, and then the atrium are the chambers of the heart on the top. So if there's a hole between those two chambers, then that's called a septal defect. And usually what happens is they're identified at birth, or sometimes before birth, from a listening with the stethoscope, and then identifying a murmur that then is further evaluated and found to be related to the defect. Many times when these are identified in young kids, they'll close spontaneously and you don't have to do anything about them. And in all the cases that we've seen, they've been closed spontaneously. And so it's important to identify it to make sure it's not causing any problems, and to follow to make sure it is closing. But we haven't had any cases where there's had to be, well, that's not true. We've had a couple cases where there's had to be surgery to fix it, but the majority of the time it closes spontaneously. So what we do recommend is usually a cardiology consultation or an echocardiogram, which is an ultrasound of the heart, for all new diagnoses, and then after birth in a prenatal diagnosis. And this is across all the different conditions. And so sometimes you could just go to the cardiologist and they'll decide if they, want to do the full ultrasound or if they just want to listen and monitor for murmurs. But because of the slightly increased risk, we think that this is an important evaluation to have. If your child is 4 or 5 and hasn't had any concerns or any murmurs, then it's very unlikely that they've had that they have a cardiac abnormality. And so I would just discuss it with your doctor whether or not you feel like it's something that needs to be done, or if based on your child's history, it just feels like there's not a concern, and we'll watch for anything if it looks like we need to do anything later on. Kidney abnormalities have been most described in XXX, and we haven't seen it as frequently in kids with XXY or XYY. We have seen it a few times in those populations, and so if your child does have a kidney abnormality and is in one of those other groups, it definitely isn't unheard of, but they're more common in trisomy X. And so in our study, I think we had 75 girls with trisomy X. There were 12% of them actually who had various kidney abnormalities, and this included things like multicystic dysplastic kidney, hydronephrosis, unilateral kidney, or single kidney. So we recommend that all kids have a renal ultrasound as well. GU abnormalities in XXY. So the important things in XXY are to look for increased risk. There's increased risk for undescended testicles, inguinal hernias or hernias in the groin region, and then microphallus, which is a short penile length. So these can happen at increased rates in boys who have XXY. And so the recommendations here are really, examination by your primary care provider to see if these things are present. And then if they are present, referral either to pediatric urology or endocrinology for ongoing care. One of the other things we can see sometimes in the X&Y variations are flat feet, or the medical term is sometimes called pes planus. And this in the pictures, what you can see is, what we call pronation at the ankle. So if you have really flat feet or lack of arches, then your ankles will kind of roll in, and you can see from behind that the kid's ankles, the angle looks more like this as opposed to a neutral or normal foot. And these are examples from behind of pronated ankles of little kids, and or from the front where you can see that there's very little arch. And so we think this happens often in the X&Y variations due to some of the ligamentous laxity that can be there, or the hyperflexibility at joints, and there's really a lot of different opinions about what you do about it. What we do is if I see ankle pronation on a physical exam, I'll look to see if it seems to be impairing balance or any kind of motor skills. And then generally I'll make a referral to a physical therapist. The physical therapist is the group at our hospital that would determine if they need orthotics. And so they would do a more comprehensive evaluation to look at if they feel like the flat feet are affecting motor skills development or physical endurance or something else. There's definitely an important aspect of treatment and further evaluation if there's any complaints of pain, but most of the time these kids don't have complaints of pain. If there are therapy, in terms of what the different treatments are, some therapists will just recommend, really supportive shoes. Others will do different degrees of what are orthotics that will be placed in the shoe, sometimes just more of an arch support, or some that are a little bit more structured, and then some even that go above the ankle, depending on the degree of problems. And then some will just say, no, we're good, we're going to watch it and wait, and we're just going to give it some time. And so, again, there's a lot of different opinions, and what we just want to do is monitor motor development and really see that it's not affecting them in terms of that or in terms of endurance. There are a lot of other medical problems that are definitely more common in the X and Y variations compared to the general population. And so here you'll see a list of them: infantile reflux, feeding difficulties, food allergies, eczema, more frequent respiratory infections, ear infections, wheezing, asthma. So these are all things that, you know, I hear in clinic a lot more frequently than we see in general pediatric populations. However, so we don't know exactly why this is yet, and I think there's still a lot of research that needs to be done in understanding these aspects. For some kids, these are pretty mild. For others, they're really significant, and feeding difficulties or food allergies can definitely cause a lot of problems. But there's nothing different related to the X and Y variation that would change their care. So generally, you know, you would seek support from your primary care provider, and then if there is, you know, there are problems that can't be managed through your primary care office, then referral to a specialist for whatever the different problem is. And then, you know, those specialists should definitely know about the X and Y variations. But again, there are no different medications or different surgeries or anything else that you would do related to just because they have the X and Y variation. So I think it's important now, we're going to start to talk a little bit about our different research studies. The diagnoses of X and Y variations is changing a lot. You know, as many people know, there are now blood tests that you can do on the pregnant woman that can look for the DNA of the baby. And this is called non-invasive prenatal testing. And what it's doing is it's leading to many, many, many more diagnoses of X and Y variations in the prenatal period. And so based on this, there's been a lot of publications that talk about finding the sex chromosome aneuploidies or the variations by looking at the mom's blood. In May of 2016, the American College of Obstetrics and Gynecology recommended that all women should be offered the option of aneuploidy screening or diagnostic testing for fetal genetic disorders regardless of age. So this was a really important change because previously the times where it was offered were really only when there was advanced maternal age or some other risk for having a chromosome difference. And this really opened it up so any pregnant woman, regardless of her age, would then be offered this test. And so this has led to a very high rate of prenatal diagnoses. And so, you know, it's our estimation that the NIPT testing could really diagnose X and Y variations in 10 to 20 times more infants, because we know right now all of those infants are not being diagnosed, and so we're going to end up identifying a lot more babies. So because we have increased prenatal diagnosis, we're getting a lot of babies, and so many of you may be some of those families who have come to our clinic or who have called us, and then we get, you know, Susan Howell, who's our genetic counselor, gets calls and calls all week long of babies who are being diagnosed around the country. So, you know, there's a lot we need to do as a group of professionals and in collaboration with Access to prepare for this. So one of them is definitely improving prenatal genetic counselors. Many people have received, you know, very good counseling prenatally, and then we hear some stories that are really not that great. And so we want to make sure that we, you know, arm genetic counselors with the information they need so they can give accurate information to families. Definitely we want to educate primary care providers and specialists on how to care for these infants and children. As much as we love seeing all the families, and the ACRC through Access is developing a network of clinics, there's definitely not enough providers to see all of the babies. And so we have to really be able to develop information for these providers on how to do this developmental and medical care for the early childhood. This includes, you know, all the medical risks and then the developmental screening. We have to understand that there's going to be a lot of babies that are now going into these early intervention services who may not have otherwise been receiving these services. And so that's going to put some increased burden on those community services. We need some good treatment guidelines and consensus statements, and this is also underway through Access in terms of being developed by the ACRC clinics and clinicians. We need some good guidelines for school districts, which can also be an area where there's a lot of education needed, and then improving access to information and treatments. And then we need to develop some interventions that are very specific and targeted towards what the developmental course of the X and Y variations are, so we can optimize outcomes. And I think there's definitely some information that we have about this, but there's a lot of work to do in terms of specific interventions for the variations. So, you know, we are, because of this influx of infants, you know, definitely want to be able to help in all of the areas in the previous slide. And the studies that we have going on, I think are going to be very significant contributions to be able to move the field forward. So we have 3 studies I'm going to talk about. One is called the Extraordinary Baby Study. The next is called the TRIXY study, and then the TESTO study. So here's our logo for the Extraordinary Baby Study. You know, a lot of times when families call us or when they have a prenatal diagnosis, basically their question is, what's going to happen to my baby? You know, we hear about all the variability and all the risks, but how do I know what's going to happen to my baby and where they're going to end up? And, you know, how can I help them get there? And so, you know, this is a really important question. So this is the simplified version. And then, you know, the model that we put in our grant is actually this version, because we really want to be able to help answer that question. And so in the first phase of the Extraordinary Baby Study, we're focusing on early childhood. It's a 5-year grant that's funded by the NIH, so that means it's your tax dollars that are paying for this, which I think makes a lot of families very happy to know that it's going towards something that's important to them. And so, you know, we have all the conditions with the sex chromosome trisomies, and then we know there's a lot of potential protective or risk factors, and we've talked about a lot of these along the way. And then we want to really understand what some of these early predictors are. So how can we tell early on what some of these later outcomes are going to be? And so are there different aspects of early speech and language skills that might help us know, okay, this patient specifically is, you know, at much higher risk for a reading or language disorder compared to maybe this other infant who doesn't have that same profile when they're younger. And so we want to understand these profiles a lot better so we can better predict what these outcomes are going to be. We also want to learn a lot more about these early gonadal function, which is the early hormonal function, right? And all of the variations. So we talk a lot about hormones in XXY often, but there's definitely important research that still needs to be done on early hormone profiles in boys with XYY and girls with XXX, and then, you know, a lot more research in XXY as well. So we're going to be studying a lot about gonadal function, and then other things like body composition or your fat to muscle ratio and metabolic rate and other aspects of growth that we know can later on be challenging. And so let's look at these and follow these from very early on in childhood. And so our first outcomes are at the 3-year age point, and because in a 5-year grant we have that much time to get to 3 years. And basically in this first grant we'll be taking all the kids and following them from birth to 3 to 4 years of age, and then looking at the different outcomes at 3 years of age and looking back to see what some of these early predictors and patterns can be, to be able to give us you know, some better factors some answers to be able to predict some of these outcomes and then be able to intervene in terms of those identified areas. You know, we have a bigger vision beyond our early childhood, is really to follow a lot of these kids all the way up through school age and adolescence and adulthood, and look at some of these things we talked about, like the learning and reading disabilities or attentional challenges or social issues later on, as well as many of the metabolic and physical changes, and then again in adolescence and adulthood where we know there's other challenges and other risks. And so, you know, we think this is hopefully going to be a very long study for the course of the rest of my career, where we're going to figure out everything. So our aims are, like I talked about before, to study and describe the profiles of all the development and medical and hormonal features in the first 3 to 4 years of life. And then to identify risk factors and early predictors of poor neurodevelopmental and health outcomes, so we can identify opportunities for interventions, and then also help guide families and counselors. And then we're going to work on developing a set of tools that primary care doctors can use. So using all our data to say, okay, which tools are the best at identifying delays so that we can make recommendations for a prenatally diagnosed patient or a patient diagnosed in early childhood of how primary care providers can best treat that child. And then we're also building a huge biobank of DNA and RNA and urine and stool and all sorts of other biological considerations, so we can then later try and figure out, okay, so what are the genes and the different metabolic pathways that are involved in all of these neurodevelopmental and medical differences. The Extraordinary Baby Study has 2 sites. It'll include one study site at the Extraordinary Kids Clinic in Colorado, where I am, and then Dr. Ross is the PI of the Nemours site that's in Wilmington, Delaware, and near Philadelphia. And so there's a nice site for kind of West Coast families and a site for East Coast families. And the important piece of this study is that participants have to have a prenatal diagnosis, and then they have to enroll at 12 months or younger. And so there are different study visits at 2 to 3 months, 6 months, and 12 months. So they have to be enrolled at one of these visits, and then they start the series at that time. And then after that, if they're not enrolled by 12 months, then they're not eligible for this study. But there are other studies, so we will talk about those. And then after they're enrolled, we see them at 18 months for a subset of the babies, and then yearly after that. And they go through a lot of different assessments when they're there. You know, generally for little and younger babies, there's not as much that you can do. And then as they get older, then they'll go through more assessments. But, you know, a lot of very careful developmental and medical follow-up. The TRIXY study is led by Sophie van Rijn from the Netherlands, and she has done some excellent work over the past decade looking at early development and you know, and later development in X&Y variation populations, specifically focusing on social development and language and other aspects of social emotional development. And the aim of the TRIXY study is to also study the different neurodevelopmental problems in these young kids. This one goes up to 6 years of age, and then to identify these different predictors of outcomes. One of the differences in Dr. Van Rijn's approach is she's been very scientific and using a lot of very more complex neuropsychological types of assessments. And so, you know, the TRIXY study has some really unique strengths in terms of the study design. It's looking at a technology called eye tracking. And so in this one, the kids are put in front of a video screen, and you can actually track where their eyes are looking and what their eyes are paying attention to in terms of different social scenes. So this is a figure from one of Dr. Van Rijn's previous studies on adults with XXY. And basically in this social scene, in typical adults, they looked a lot at the eyes and then the mouth, and they would alternate. So the red is where they were looking the most. And then in adults who had Klinefelter syndrome, they tended to look more at the mouth and not at the eyes. And so, you know, this is an important clue to if there are social challenges, maybe we need to start training and talking and teaching a lot more to look at the eyes so that they can have better social perception. And so this is going to take, you know, some of this work that's been done in older children and adults and really bring it all the way down into infancy to see where these challenges start. She also looks at skin conductance and heart rate and all sorts of other very complex but very cool methodologies. So for TRIXY participants, they can have any of the trisomies. They can enroll. They can't enroll before 12 months of age. So they have to start enrollment at 12 months of age, and they can go all the way up to 5 years of age. And they can have either a prenatal diagnosis or a postnatal diagnosis. So this will include a broader population of patients, and then the older patients are also eligible for this. University of Colorado is the site that anyone in the U.S. would participate in, but it's also happening in Leiden in the Netherlands and in Belgium. And then there's 2 study visits. So there's a baseline visit and then 1 year later. And then, like we talked about, a lot of the developmental assessments, and then the video eye tracking and physiology and different procedures. And then Dr. Davis is doing a study that's called the TESTO study, testosterone effects on short-term outcomes in infants with XXY. And the aim of this study is really to look at the effects of testosterone therapy during the mini-puberty of infancy, and looking at those effects on physical development, on body composition, and then on early developmental outcomes. So just a little bit of background is that generally testosterone in males with XY increases and has this mini puberty in infancy. It's pretty flat until puberty, when it increases again, and you go through the typical pubertal changes. In infants with XY, we think, and some research supports that this mini puberty is blunted, and then we also know that you know, as they go on into adolescence, they tend to start puberty at a normal time, but then often don't make as much testosterone as typical peers, and so at some point there are often indications for starting testosterone replacement therapy in this group. But this study is going to focus actually on this younger age. And talk about and look at the effects of testosterone supplementation in this early age group. And so, you know, there's a lot of questions about what the effects are of testosterone replacement in infancy, in both in the context of physical development and then in the context of neurodevelopment and developmental outcomes. The strengths of Dr. Davis's study design are that this is a, you know, the design of the study is definitely more rigorous in terms of comparison to previous studies that have looked at testosterone, that have been much more retrospective and less controlled in terms of those studies. And so this one decreases the biases that exist in many of the previous pilot and preliminary studies. It's double blind, so no one knows whether or not they're on treatment or placebo. It's placebo controlled, which is really important anytime you're really trying to determine the effect of a medication, because it decreases also the bias of thinking, you know, that the medication is doing something. And then it's prospective, so it allows opportunity for everybody to be followed throughout the course of the study, and accounts for all the patients that may be lost to follow-up, whereas some of those other studies that look retrospectively, they lose a lot of those patients that have important information. So this is just at one site. It's going to be done in Denver. There's 60 infants with XXY that are going to be in the study. This is also funded by the NIH through the NICHD through a K award to Dr. Davis. So again, your tax dollars. And then there's 3 study visits, one at baseline, one 3 months later, and then another 3 months later. And then this is the design, is that all of the infants will be enrolled and they're randomized. Half of them will receive testosterone first. The other half will receive placebo first. Again, no one knows which group you're in. And then the outcomes, the primary outcomes will be the outcomes at this 12-week visit. And then they get another 3 months of testosterone and placebo, and then they'll be monitored at this week 24 visit. And so, and infants who are in the TESTO study are also eligible later on to go into both the TRIXY study and then also can be in the Extraordinary Baby study as well. This is a little pea pod that looks at body composition, and so the babies go in there and it measures just through sound waves what their muscle and fat ratio is. So these are the 3 studies, and it just gives a summary of kind of when and where they're enrolled and what the different diagnoses are. And if anyone is interested, then I have all the information here. The other important thing is that all of the studies have other inclusion or exclusion criteria. So if you're interested in participation, we still have some other questions to make sure that you're eligible for the study. Like I said before, they're funded by the NIH. There's a travel budget. It's definitely a budget. You know, the NIH doesn't give us a lot of money for travel, but for families who are from out of town, there can be airfare and, you know, hotel accommodations that are provided. Again, you know, there's nothing luxurious going on, but we'll definitely help coordinate that. And then, like I said, babies can be in more studies, and now we're all recruiting, which is really exciting. So if you're interested, these are the Extraordinary Kids Clinic at childrenscolorado.org, or the number here is Susan Howell's number. There are separate numbers and email addresses for each of the studies, but I think this is the easiest thing from here on. And then this is just a big thanks to you know, a lot of collaborators and providers, and then also a lot of patients and families who have been in our previous research. And so you know, there's been a lot of people who have helped us build these programs. And now I just wanted to take the opportunity to answer any questions and go from there.
We have a number of questions that have been typed in, so I'll read them off to Dr. Tartaglia. The first one is, what's the likelihood for someone with an aneuploidy to pass the extra chromosome on to the next generation? And how does this change with increase in maternal age? I think this would be for XYY or trisomy X in adults.
Yeah, and so, you know, there's a lot of, there's a complicated answer to that. So generally, in XXY, fertility problems are usually present, right, in males who have XXY. And so if there is the opportunity to identify sperm, many of the times that sperm does not have aneuploidy in it. About 50% of the time, and it depends on the literature you look at, but in general, about 50% of the time, an adult male who has XXY, if he goes into the reproductive urologist, they can go in with a little surgical procedure and see if they can identify sperm, and in about 50% of cases, they can. And then when that's there, if that's used to then do IVF or be inserted into an egg, the majority of the time there actually isn't aneuploidy. It's a little bit higher of a risk compared to males without XXY, but in general it's not very high, because the idea is that actually those sperm were produced by cells that probably kicked out the extra X. So many places will do what's called pre-implantation genetic diagnosis. So before they would implant any embryos, they would actually test the baby to see if there was aneuploidy there. In girls with trisomy X, we still have a lot to learn. Definitely in women, the more they advance maternal age, you have a higher risk of passing on aneuploidy, even if you don't have trisomy X. And so we're still learning a lot about those risks in trisomy X. In general, we know many women with trisomy X go on to have normal and healthy babies who don't have aneuploidies, but there have been cases where it's been passed, where the mom and the child both have trisomy X, and so it's not unheard of, but in general, most of the cases, the women with trisomy X don't have infants with aneuploidy. And then in XYY, there's still, you know, a lot of research to be done, but again, you know, a slightly higher risk, but not significantly higher.
I have a question. Are the same loci silenced during X inactivation across the population, or is this the reason for a wide range of phenotypes?
Yeah, so, you know, on the X chromosome, generally when people have two X chromosomes, there's one X chromosome that's inactivated, or basically these little methyl groups, you know, connect to some of the genes on that, or to the majority of the genes on that chromosome, and then inactivate it. And so what happens when you have XXY or a trisomy is that you still have X inactivation. So if you have an extra X, then one of those, one of your X's is inactivated, but that's random. You know, sometimes it's one of the X's and other times it's the other X. And so, and the other thing that's important is that not all genes on the X chromosome are inactivated. And so even in a typical XX cell, there's still 10 to 15 to up to 20% of the genes on that second X that aren't inactivated. And then when you end up having trisomies, you know, there's definitely been some research to support that the degree of inactivation or of methylation of those genes can be different. And so if you think about, you know, genes that might have some variability between themselves as they are, and then you have differences in the amount of how much they're expressed because of how much they're inactivated, it definitely explains, you know, probably explains a lot of the variability in some of the features. There's still a lot more to understand. We don't know the specific genes on the X or Y chromosome that lead to some of these developmental features, to most of the developmental features.
We have a question about surveillance. This mom says that her primary care doctor has said that he doesn't know very much about trisomy X. What should we do at the well child visits? I think you probably covered that in the slides, and I'm wondering if we can provide a copy of the slides to the people who attended this webinar.
Absolutely.
Okay.
Yeah. But I mean, in those situations, I would say, the other thing is there's there's a paper we wrote on trisomy X that includes at the end a figure that has a lot of recommendations in terms of developmental testing, and then just kind of all the medical recommendations in the summary table. And so I think that's also available through Access. It's first authored by Kristen Wigby, and that is also a good thing to bring to your provider. But I would say, hey, you know, we know she's at risk for trisomy X, and the doctors all say we need to do formal developmental screening, and this is what we need to do. So these slides would be helpful for that.
Hi, this is Robbie Miller. I just wanted to remind everybody that the entire webinar, the audio and the slides, will be made available on our website in the near future.
Okay. I also have two questions about the clinic consortium. And people are wondering where the clinics are and where they can get a list of them. If you go on to the homepage of the genetic.org website and you click on resources, scroll down to clinics, the entire list of the clinics is there along with all the contact information. One mom asked specifically about any XXY specialist in the Chicago area. There is a consortium clinic at Rush, so you can consult that clinic. What other medical conditions do our boys with XXXY? What do they have to deal with? Any additional medical conditions?
Any times with the tetrasomy, so including XXXY, many times we'll see more congenital malformations. So sometimes you might see a higher rate of congenital heart disease, higher rates of seizures, higher rates of palatal abnormalities or club foot. So all of those things, usually they're pretty evident, but they definitely are, it's a little bit more complex often in terms of those medical findings. And then many of the immune challenges and the other asthma and allergies and all of the other things on that list are still very common in boys with XXXY. But if you look at the whole group, they tend to have those more frequently compared to just the trisomies. So I would say that this whole list that we gave are definitely all things that should be considered and that can be associated. And then there's some other GI, different types of challenges that can be there as well. And so, but in general, that list includes the ones we would also see in XXXY, as well as some additional increases for seizures and other malformations.
Okay. Are there treatments for microphallus?
Yes, there are. Generally, if it's identified, then the patient will be referred to see a urologist or endocrinologist. And when they see that doctor, most of the time what will be prescribed is a short course of testosterone therapy. So it's very similar to the study that I described that Dr. Davis is doing. They'll do one injection of a small dose of testosterone once a month for 3 months. And usually that leads to a significant improvement in penile length, such that they no longer meet criteria for microphallus or for a short penile length. So we know that that treatment is often very safe, and then can lead to the improvement of the phallus length.
How do I tell my child about his genetic condition? He has Klinefelter mosaicism.
Yeah, so we have a lot of great resources for that, which are also on the Access website. I think it's really individual between kids, and it depends a lot on what types of challenges they're having, if any, and then also, just a lot on the family and even, the culture within the family. So because this comes up so often, there's definitely, I know, some of these sessions that have been videotaped at various conferences. And so I would definitely look to previous Access conferences. There's whole sessions that we've done on how to talk to your kids about the diagnosis. There's also a series of books that we developed for kids that are picture books. The one for XXY is called Gregory and His Extra X. And if you go on Amazon, you can purchase that book. And it is a story of kind of the day in the life of a child who has XXY. And there's also these books available for trisomy X and XYY and XXYY. And so, and those are also linked on the Access website. And then we also developed a series of pamphlets that I know are available through the Access website as well, that are basically how to talk to your child about the diagnosis.
Okay, another question. What if the therapists at the children's hospital and the school district don't agree? And her child got only speech, whereas OT and speech were recommended, apparently.
So many times the school districts will say that they don't qualify for OT if it's not an educational need. So if it's something like sensory processing or some kind of self-care skill that doesn't involve something needed for academics, many times they won't provide academic or occupational therapy at school. So those would be the type of cases where we would find a private clinic if we felt like it was really important. And then, you know, you can advocate and use a lot of, you know, recommendations and resources to see if the school district will implement OT. But many times if they feel like it's not needed, then having them, you know, it might take a little bit to try and convince them that it is needed. Or they might give you, oh, sure, we'll do it for 15 minutes a week or something. So, you know, those are the types of situations where if we feel something's really needed, then we would also make sure they're getting it privately. And then if they're getting speech therapy, for example, in 2 different places, we really encourage the therapists to talk to each other so that they might not be working on the exact same goals, but we don't want them working using conflicting types of strategies, right? And so it doesn't have to be, you know, long conversations every week, but there should be some communication between the therapists so that people know what people are working on. And then, you know, sharing of reports and goals and those types of things between the therapy teams.
Okay. Has any research been done into the level of risk depending on position in the family? If the child has older siblings, are the risks of delays less or more?
I don't think we've ever looked at that. You know, that is something we're actually going to be looking at in the baby study, is just, you know, what are the impacts of siblings, and so that'll be some information that we'll have as part of the extraordinary baby study. Families, you know, will report different things. Some of the families will tell us about how when they have kids who are, if their child with the X&Y variation is the oldest, sometimes if they do have delays, the younger kids are kind of down there, you know, developing more typically, but then pushing them a little bit. And then the other way around also is if they're the youngest kid, then many times, depending on the ages, the older kids are like little mini therapists running around. They're playing with them, they're talking to them, they're trying, you know, and the little kids are very motivated to try and be like their older siblings. So I don't have any specific research or findings that, you know, tells us one way or the other, but I think there are definitely positive aspects of having siblings around in many cases.
Okay. Another question about trisomy X. How underdiagnosed do you think trisomy X might be? What are the percentages of affected girls that are asymptomatic of their variation?
Right. So, you know, there is some research and there are some papers on this, but I think we still have a lot to learn. So in general, right now, we think that maybe 10 to 15% of all individuals with trisomy X are actually diagnosed. So that means there's a lot out there without a diagnosis. Now, that being said, it doesn't mean that that 85% that are out there are not affected, right? And so they may not have ever had genetic testing, but there's likely many of those women who had, you know, milder or, you know, maybe more significant learning challenges in school, some features of anxiety, some of the speech and language challenges. And so those things may be there, and then no one ever actually tested them and identified the trisomy X diagnosis. But there are likely, and we've found through this non-invasive prenatal testing, that there are sometimes they get a false positive where it's actually mom who has trisomy X and it's not the baby. And in those cases, you know, there are many women identified who had no idea they had it and didn't really have many challenges. But then, you know, there are also times where they look back and say, oh, now that explains why I had some of these challenges. So, you know, we have a lot of undiagnosed cases, and then of those who are undiagnosed, there's probably a lot of variability even with that of how affected they have been.
Okay. Has a link between sex chromosome variations and autism spectrum disorders, including ADHD, been established? Are treatment interventions offered to patients with these conditions alongside interventions for XXY or other X and Y variations?
Yeah. So, our team has done a lot of research looking at the association between autism spectrum disorders and ADHD in individuals with the X and Y variations. There's definitely higher rates of both in the variations compared to the general population. And then there are differences between the different conditions. So in our autism study that was published last year, we had groups of kids who had XXY, where we found about 10% risk of autism. We had kids who had XYY, where we found about a 30 to 35% risk of autism. And then in XXYY, it was about 45 to 50% of the group who had autism. And then in girls with trisomy X, it's usually more similar to the XXY rate. So we usually hear about autism in 5 to 10%. So those are important numbers. It shows that there definitely is an association in all of the variations, more common in the boys who have an extra Y. But the important thing is that there also is, very likely bias in those samples, right? These are studies that they're not drawn from our clinic, but they're patients who are, participating in research through our clinics and through our programs. And many times families who might have children with autism are very motivated to come and participate in research. And so we definitely recognize that we have some bias there. But when we do identify autism, and we do a lot of evaluations for autism as part of our program, then we make specific recommendations for autism services related to social skills and other kinds of social communication development and specific interventions that way. And then ADHD is also very common. We know that frontal lobe development, which is the part of your brain that is responsible for attention and inhibiting impulses and many other of those what we call executive functions, is that frontal lobe is less developed and kind of less connected in the X and Y variations. It's very subtle, but we do know that those differences are there, and we often see those differences in terms of the behavioral features and the challenges that many of these patients face. And so I do a lot of treatment for ADHD in my clinic if it's diagnosed using medications, and then a lot of recommendations for the types of behavioral strategies and education supports that kids with attentional deficits also need. And so I think it's an important consideration for all kids who have X and Y variations. One really important thing about the ADHD piece is that, many kids, especially the boys who have XXY or girls who have trisomy X, are not hyperactive. So they don't have that H piece in there. And they're more these kind of inattentive, distracted, less motivated, difficult to initiate things, some of these things that definitely can still be attentional deficits that would benefit from treatments, but you're not going to hear about it as often because you don't have the hyperactivity or the problems that are, these kids aren't causing problems in the classroom because of the hyperactivity.
We've limited those with whom we share our daughter's diagnosis. Would it change anything about how her speech therapist treats her if she were aware of the diagnosis?
I think it's important for therapists to know the diagnosis. And the example that I gave related to kind of knowing that of the profile of XXY, the challenges that we often see are in things, there may be a risk for apraxia, there's challenges with word finding, there's a lot of, literature that's out there related to some of the speech and language profile that we see. And so, as a treating provider, it really helps me to know what my patients are vulnerable or what their profile may be, so that we can make sure we're targeting those areas. A good speech therapist is still going to look at a child individually, but I think it's important for therapists to know, because there might be different strategies or different assessments that they would use or assessments they would do related to the specific risks or differences in XXY or in any of the variations. So for therapists, I think it's important for teachers. Some families choose not to share with the school district exactly what the diagnosis is. Some, again, choose to share some aspects, or they might share a diagnosis like ADHD or dyslexia, but they won't share the genetic diagnosis. There's a lot of variability there. So again, I point you guys to all the AXIS conferences from the past where we've talked a lot about these in different sessions, and you can hear different opinions from other people who were in the audience. A lot of these were very interactive sessions where there were panelists of individuals who had X and Y variations, talking about when they learned about the diagnosis and how they talked to other people about it. And then there's those pamphlets as well on the AXIS website that talk about it as well.
In light of the presence, although rare, of some XXY females, do you think we should change the dominant references to men and boys in our literature to children, adults, and individuals to encompass everyone?
I think as much as we can, we should. Just be inclusive of everybody. I think, in general, the world is changing that way in many ways, right? I got an email the other day from someone who had their pronouns on the bottom. So it was, whatever their name was, and then my pronouns are, and it was, her, she, and that she used feminine pronouns. But, how we identify, I think, is it's becoming important to be a lot more inclusive.
Let's see, what else do we have? Another question, what about buried penis? I'm assuming with XXY or one of the Klinefelter variations.
Yeah, so sometimes buried penis refers to, a penis that it might be buried inside a fat pad, the suprapubic fat pad. So sometimes those kids meet criteria for a diagnosis of microphallus, but other times they actually just have a fat pad that's pretty big, and if you actually push it down, their phallus length is actually pretty normal. And so, for that, what I would do is, see a urologist and see if they felt like they met criteria for microphallus and if there was anything they needed to do from the testosterone perspective, or else other times as they grow and kind of that fat pad goes away, many times the penis emerges. And in diapers, it doesn't make any difference. But then obviously you think about when they get older, from the kind of social perspective of peeing in the bathroom or just being able to pee without making a big mess, it makes a difference later. So sometimes there are treatments to increase penile length with the idea of, being able to have kind of more functional or less messy urination after being out of diapers.
Yeah.
But the urologist is the right person for that.
Yeah. What are the odds of having a second child with an X or Y variation if the first child has XXY?
Pretty low. It's not, most of the time these are not inherited conditions. And so the majority of the time you're not going to have a second child with the same variation. However, there's always exceptions to that. It's really, if mom or dad is a mosaic, but generally if mom is a mosaic, sometimes there are eggs where there might be extra X's in the eggs, and then again, if they're older age, that can increase risk again. So it can happen, and I've had families where there have been two boys with XYY in the family, and then we end up finding out dad has XYY, and I've had triple X run in families. So we've had things run in families, but it's very rare. Yeah,
I know two families where one child has XXY and one child has XYY.
Oh, wow.
Very, very rare. So
yeah, very, very rare.
Okay. Do you think it's possible for boys with XXYY to be asymptomatic?
I think it is very rare for boys with XXYY to be asymptomatic. I work with a big population of guys with XXYY. I think, again, we probably identify those who have more significant challenges, because then when they're identified, they're being tested for some reasons. So there might be some out there who are less challenged and maybe are, have fewer challenges, but I suspect, just given the spectrum of the patients that I have seen, that there will be some sort of developmental feature. And we know that, the majority of the time in XXY, we're also going to have the hypogonadism or the testosterone deficiency that develops in, many of those, or the majority of those young men as well. And so while they maybe are less symptomatic from the developmental perspective, the physical features are still going to show the features of the extra X chromosome.
Yeah, I have another question of whether or not seizures are common in X and Y chromosome variations.
Yeah, so we definitely see an increased rate of seizures compared to general population. We generally quote about 10% for all of the trisomies, and then it's a little bit higher for the tetrasomies. I know in XXYY we have about 20% of boys who have had seizures, and so so it increases with the increasing number of X's and Y's, and they're higher. The majority of the time when kids do have seizures, they're fairly easily treated with standard medications that neurologists use for seizures. And so if there are any kind of funny staring spells or clear seizures, then obviously the treatment goes to the neurology teams to figure out the best medications.
Okay. Are you finding that children with XXY present with low IQs?
If you take a big group of patients with XXY, their IQ on average is 5 to 10 points lower than your average group of kids with XY, or boys without X and Y, or with boys without XXY. But that by itself does not mean that each, you have to think still of each individual. So when you have a group where the average is 10 points lower, it means still within that group there's a lot of variability, and many of those kids will be average or above average. But there also will be a slightly higher percentage of those kids of the entire group that will show IQs that are a little bit lower than your general population. So so on average, we see IQs that are slightly lower. The more important pieces are that there can be variability in IQ. So in terms of the different aspects of IQ. So generally in XXY, we see that more verbal or language skills tend to be more impaired compared to nonverbal IQ, which is some of these more visual spatial skills, which can be nice areas of strength. So the full scale IQ score doesn't necessarily describe the individual, because if there's a discrepancy between verbal skills and nonverbal skills, then the average kind of score in the middle doesn't really tell you where they're functioning in either area. The other thing is that IQ does not tell you necessarily about learning disabilities. So you can have an average or above average IQ, but still have a reading disability. And so, beyond just having IQ testing, it's really important to have academic testing to understand where academic skills and reading skills and all of those pieces are as well. And then the other really important thing is that IQ does not necessarily tell you about all those executive functions we talked about, and it doesn't necessarily tell you about all those adaptive skills or those life skills. And so, there can be kids who have normal IQs who have challenges in those areas that can be cause a lot of disability, and then vice versa, kids who have maybe lower IQs but strengths in some of the other areas where they're not as affected. And so understanding how all of those components together lead to, what each individual is doing is really important.
Okay, I have a question from a mother of a 16-year-old who's just been diagnosed with XXY, and it is, will there be a webinar for the older kids? And the answer is yes, we just don't know when yet. Okay, I've got another question. Is it normal to have retractile testes at 3 years of age?
They need to be monitored for sure. So retractile testes are testes that you can push down or pull down, but oftentimes then kind of spring back up into the inguinal canals. And so if at 3 you're seeing that, I would make sure you're following it closely with your primary care provider and or your urologist. We've had some kids where if you're not following it, you know, people say, oh, they're down, we can always get them down. But then when they're 8 and 9 and 10, you can't get them down anymore. And so in some cases, they'll just come down and they'll stay down. In other cases, you know, they do need surgery to be able to tack them down. And so I would follow along with your primary care provider or a urologist just to make sure and see what their recommendations are for ongoing monitoring.
Okay, we have a question from an adult with XXY. He said he has always struggled to do psychometric testing and complex behavioral questions as part of job applications and interviews. Are there interventions that could be offered to children to increase their processing capabilities later in life?
You know, the intervention, well, there are not specific interventions that we can say, okay, here's a specific intervention for, you know, processing in XXY. But, you know, what we do feel like is that the detailed evaluations that we do in terms of neuropsychological skills for each individual can help identify where those processing difficulties are. And then for that individual, there may be strategies or programs or something else that might help. And so, you know, again, there's a lot of kind of individual treatments and evaluations, but we want, if we identify those challenges, I think it's really important. The other thing is for things like, you know, standardized tests and those other types of testing environments where it might be an area of challenge, then those are definitely areas where you can teach strategies on how to take a, you know, multiple choice test and do a lot of practice sessions, and if needed, give extra time on tests. Many times people will start to feel some anxiety because something might be challenging, and then the anxiety makes them not do as well on the test, and they start not answering questions right. And so taking away that time limit can often lead to significantly improved performance, and we'll often have IEP accommodations that in school, you know, they have to have testing in a quiet room and extended time on their tests, and even in standardized tests like for college and other things, you can have accommodations that can support having extra time. Or people reading you the questions, or all sorts of different things depending on what your needs are.
I have another question regarding XXY. Is it likely that you'll be able to extract sperm after a boy commences testosterone?
That's a question for the urologist. And if you ask 10 urologists, you're going to get 10 questions or 10 answers. But generally, when you're giving exogenous testosterone, it decreases your endogenous production of any sperm if you are making it. And so definitely for adults, when they're going through all the procedures with TESTO and ICSI to do, you know, the IVF and the fertility procedures, many times the urologist will take them off of the testosterone that they're receiving because then it does increase the likelihood of being able to retrieve the sperm. So again, it's going to be different practices and medications and different procedures for depending on which clinic you're at, and that is I think a really important area of research, but also not my field, and so I'm trusting all these smart researchers to tell us more in the future.
Okay. I've got another question. My son was diagnosed this year at age 5. Do you recommend seeing doctors familiar with XXY after this diagnosis for an initial visit? I'm not sure what that means. Yeah.
You know, I think after an initial diagnosis, it's really helpful to see a specialist who can tell you, okay, for your child, these are the things that, you know, we definitely see in other kids with XXY. Maybe these are some of the unique strengths or challenges that might not go along with the condition as well. Here's kind of where, you know, and having someone knowledgeable answer all your questions. You know, so I think evaluation at one of the clinics after a new diagnosis for that age is really important. And if you can't make it to one of the clinics, then talking to your primary care provider about who might be the best person in your area. Sometimes it's a geneticist, or sometimes it's someone else who has expertise, a developmental pediatrician or someone else, so a psychiatrist. So there's different people who may have expertise, and searching for those would be positive. I think Access now has a list of professionals too, right, Jenny?
Yes.
That was recently added.
Mm-hmm.
So there's a list of providers on websites that might be a good resource also.
Okay.
And that this is Robbie Miller again. That's listed on the homepage under by scrolling down and clicking on Professional Directory.
Okay. How can I find out if in my state, which is Georgia, if it's a qualifying state simply by diagnosis, or if a developmental delay must be identified in order to receive state support? I'm assuming this is for early intervention.
Yeah, yeah. So there's probably a Department of Health website that talks about early intervention and qualifying diagnoses, and you know, I would start with there. Your primary care provider might know or might be able to refer you to the right place. Here we have, you know, in Colorado, there's regional centers, and then it's definitely listed on many of the websites for different disability groups and different disability agencies. So I would start just kind of looking on the internet, and then if not, you should at least be able to find someone from there who can point you in the right direction.
Okay. I think that we've gotten most of the, I'm just looking through to see if I've missed any of the questions. I have a couple that are a little garbled, so I might mix just because I can't really read them. But I think that we probably, we've probably gotten to the end of the questions. So that was a lot. Okay.
So, well, thank you, everyone. You know, it's challenging to do these webinars when you don't see feedback from people, right? So I hope it was helpful, and I shared some good information. And then, you know, also if there's any people who are interested in being parts of the studies or obviously involved in the clinic, then, you know, the resources and our contact information is all over the internet, and then on the slides that I'll share with Access that can be shared with everybody.
I just got another question that came in that said, will this seminar be available online as a recording? And the answer is yes. Probably take about within the next month or so. We have to format it. And then we've also gotten some feedback coming in on the question line saying, thanks so much for your time. Really helpful. Great webinar. So anyway, thank you very much to all the attendees.
Yeah, I agree. Thank you.
Okay. All right.
Okay. Bye, everybody.
Bye-bye.